Thank you, sir, for this nice introduction. So good morning, everyone. At the outset, first I would like to thank Yashoda Groups of Hospital and Dr. Biswes for providing me this opportunity. So my respected teachers, seniors, and my dear colleagues and friends. So within next 20 minutes, we'll be mainly focusing on nuts and bolts of polysomnography. So this is the outline of my presentation. That is types of polysomnography, when to perform polysomnography, when not to perform, and the parameters and channels used in the sleep study. So this you can see a patient undergoing polysomnography. A lot of leads are attached to monitor your EEG activity, EMG, EOG, abdominal and thoracic belt, saturation, pulse oximetry. So depending upon the channels and parameters used, there are different kind of sleep studies like level 1, 2, 3, 4. So this looks simple that some leads are attached to a patient while sleeping and undergoing sleep study. But the problem arises when you see this. This is a hypnogram of a patient after 8 hours of sleep study. It looks a bit complex, but believe me, if you know the individual channels and parameters of different agents used in sleep study, but this is not so complex. And if you know the individual channels and parameters that are being used in sleep study, suppose a troubleshooting is occurring during your polysomnography, you can solve this. This can also help you in solving the artifacts. So coming to types of polysomnography, there are 4 types of polysomnography, level 1, 2, 3, and 4. Level 1, obviously we all know that this is the best level of polysomnography. It has 7 channels, 4E. One is for EEG, one for EOG, one for EMG, basically to detect the sleep stages, and another is for ECG. Then for your flow, nasal thermistor and nasal cannula. For effort, there is abdominal and thoracic belt. And for oxygenation, there is pulse oximetry. So all the 7 channels are there in level 1 polysomnography. And you can also document the body position in level 1 polysomnography. Leg movement also you can attach to detect any PLMS is present or not. And personal intervention is possible. This is the most vital part in level 1 polysomnography. A sleep technician or doctor must be there during the polysomnography at night because something is happening during the night. Suppose if some lead is getting out of the patient body, so the whole sleep study might get wasted. Suppose your pulse oximeter is getting out of your hand, then the whole sleep study might be wasted. So that is why personal intervention is possible in level 1 polysomnography. And in diagnostic person, if you are getting some kind of signs and symptoms of OSA, then you can also titrate in level 1 polysomnography. Coming to level 2, it is same as level 1, but there will be no personal intervention. So no attendant will be there in level 2 polysomnography. That is the difference between level 1 and level 2. Coming to level 3, 4 parameters are used in level 3, that is respiratory effort, and airflow, ECG, and saturation. So you are not detecting the sleep stages in level 3. So level 3 is bypassing the sleep stages. Body position is possible, leg movement optional, personal intervention is not possible. This level 3 polysomnography is more commonly known as portable monitoring or home sleep apnea testing, HSAT. Then level 4, minimum 1 parameter is used, that is oxygen saturation or effort, so it is not of much use. So either you can go for your level 1 or level 3. So what is the difference between this level 1 and level 3? That we have to know. So as I've already mentioned, these sleep parameters are EEG, EOG, and EMG. These 3 things are required for sleep stages. So I will be focusing on sleep stages in the next talk. And rest of the parameters like respiratory airflow, effort, snoring channel, these are known as, used in portable polysomnography. This is known as polygraphy. So when polygraphy is mixed with sleep parameters detection, this is known as polysomnography. That is the difference between polygraphy and polysomnography. In polygraphy, you are not detecting the sleep stages, but in polysomnography, you are detecting the sleep stages. And the detection of sleep stages is also very vital for your monitoring point of view, for titration point of view. That will be dealt in the subsequent lectures. So So what is the difference between polygraphy and polysomnography? Coming to polygraphy, it is simple, less technical skill and labor intensive. It increases the accessibility and lower cost. Setup and validation time is considerably less. It can be used at home in the patient's familiar environment, avoiding the first night effect. What happens sometimes in level 1 polysomnography, patient will not sleep in the first night. So that is the biggest disadvantage, I must say, in level 1 polysomnography. That happens in some kind of patients, not all. Coming to polysomnography, it allows for accurate physiological measurement and sleep stage distribution. Special clinical endpoints like sleep onset latency, REM latency, sleep efficiency can be detected from polysomnography, not polygraphy. It is essential for accurate diagnosis of certain sleep stage disorder and state and dependent sleep disorder and less chance of data loss. What I mean by data loss, as one attendant will be there in level 1 polysomnography, something is happening, he can correct it. So there is less chance of data loss in polysomnography as compared to polygraphy. Then the next question arises when to go for this level 3 sleep study. Level 1, we know it's the best. In all the patient, you can go for your level 1 polysomnography if it is available. But level 1 polysomnography is not available in all the centers. So you have to manage with your level 3 polysomnography. So in which kind of patient you can go for this level 3 polysomnography? Patient who has a high pre-test probability of moderate to severe OSA. No associated comorbid medical conditions like severe pulmonary disease, neuromuscular disease, congestive heart failure should be there. No clinical suspicion of other sleep disorders like central sleep apnea, narcolepsy, PLMD, parasomnia, circadian rhythm movement disorder should be there. It is not for screening of asymptomatic population. Why it should not be used in asymptomatic population? For screening in asymptomatic population, majority of the patients belong to mild group. So in mild patient, majority of the events are during the supine and REM sleep. So this polygraphy, as it is not staging the sleep, we will unable to find out majority of the events. So polygraphy or level 3 should not be used in screening for asymptomatic population. Level 1 we have to use there. Then patients who cannot move because of mobility, safety or critical care illness, then the level 3 or portable monitoring may be the best for its use. Then unattended PM may be also used to monitor the response to CPAP treatment. Suppose a patient already underwent level 1 polysomnography, he is on CPAP therapy, you want to know what is the response on the treatment. In that point of time, you can go for your level 3 polysomnography. Then there is a major difference between HI of portable monitoring and level 1 polysomnography. Maybe in subsequent lectures, you will know what will be HI, that is apnea hypopnea index. So HI in portable monitoring is usually lower than the HI in polysomnography because portable monitoring records total recording time, whereas polysomnography records total sleeping time. It cannot also detect hypopnea based upon the arousal. In scoring, you will know that hypopnea scoring is based upon desaturation or arousal. As portable polysomnography is not detecting your sleep stages, so this will miss some of the hypopnea events. So obviously, the HI in portable monitoring will be a bit lower than the PSI, but sometimes it is higher. So in which condition it is higher? There is a hypothesis that patient sleeps better and REM sleep achieved better when a patient is sleeping at home because majority of the events will occur during the REM sleep. That is why in some kind of patients you will see majority HI in portable monitoring will be greater than the HI of polysomnography. And sometimes the respiratory events are marked when the patient is awake. Then coming to types of polysomnography, we'll all know diagnostic, in which we have to diagnose the patient that is having OS or not. Therapeutic, when a sleep apnea is diagnosed, a follow-up study to adjust the CPAP level, and split night. First half, you have to go for your diagnostic polysomnography, and the next half, you have to go for your therapeutic study. Then coming to indications of polysomnography, for a pulmonary physician, the bread and butter is a sleep-related breathing disorder. So in a case of respiratory problem, there are three kinds of polysomnography: diagnostic, repeat, and follow-up. Diagnostic for diagnosis of sleep-related breathing disorders, and preoperative PSG before planned surgery for snoring or OSA. Whenever you are going for an intervention, let be a surgery or oral appliance, you have to document by doing a sleep study that your patient is having OSA or not. Then repeat polysomnography sometimes indicated when the initial result in a high probability case is there, but the result is negative. So when there is a clinical suspicion is high, but the fast test is negative, in that case, you have to go for your repeat polysomnography. Then after 10% weight loss in a patient on CPAP, to see whether CPAP is further required or not. Then follow-up PSG after surgery, after using oral appliance, you can go for your follow-up PSG. Indications of polysomnography in non-respiratory sleep disorders. We all know that for OSA, polysomnography is a must. But it is also required in some non-respiratory sleep disorders, like narcolepsy. Narcolepsy is excessive daytime sleepiness. So before stamping the patient as a narcolepsy, you have to rule it out that your patient is not suffering from OSA, because OSA patient also presents with excessive daytime sleepiness. So by performing a diagnostic polysomnography, you have to first rule out that your patient is not having OSA, then you can go for your MSLT to diagnose narcolepsy. Then parasomnia and seizure disorder, when you should go for polysomnography? When nocturnal seizure is suspected, presumed parasomnia, or nocturnal seizure disorder doesn't respond to the conventional treatment, presumed parasomnia which is injurious to the patient or others, and presumed parasomnia which has atypical features. In these conditions, you have to go for your polysomnography in non-respiratory diseases. PLMS, sleep-related movement disorders, you have to go for polysomnography. But mind it, there is no indication of polysomnography in RLS, that is restless leg syndrome. It's a clinical diagnosis only. So there is no indication of polysomnography in RLS. Insomnia, sleep-related breathing disorder is suspected, you have to go for polysomnography. PLMS is suspected, initial diagnosis is uncertain, treatment of insomnia fails, and precipitous arousal occurs with violent and dangerous behavior. In those symptoms are associated with insomnia, then you have to go for your level 1 polysomnography. Then, in which circumstances you shouldn't go for your polysomnography? Routine evaluation of a patient doing well on CPAP treatment. So there is no indication of repeat polysomnography. Evaluation of asthma or chronic lung disease patient unless OSA is suspected. Routine evaluation of insomnia or uncomplicated parasomnia, it is not indicated. Evaluation and treatment of RLS, as I have already mentioned, and evaluation of the circadian rhythm disorder. Then indications of when you should perform your polysomnography during titration. Ideally, during titration, a full night polysomnography should be done. It is the best thing. But sometimes what happens, majority of the patients will not come for titration study. So in the same night, you have to go for split night polysomnography. So when you should go for split night polysomnography? When your 3 hours should be remain after diagnostic study for titration, and the initial 2 hours, the HI, apnea-hypopnea index, should be more than 40. And it may be 20 to 40 if it is associated with longer apneas and severe desaturation. In these conditions, you can go for your split night polysomnography. So that is all about indications and indications of polysomnography. Then next comes to the channels and parameters used in polysomnography, such that your subsequent lectures will be easier for you. So these are the things we used in polysomnography. These are the EEG and ECG leads, nasal cannula, nasal thermistor. These are abdominal and thoracic belt. This is snoring channel. This is EtCO2, end-tidal carbon dioxide, transcutaneous CO2, and pulse oximeter. First, coming to EEG. It is basically to identify different states, that is REM or non-REM, and stages of the sleep, whether it is in N1, N2, or N3. Electrodes are placed on the scalp in a symmetrical manner, and the electrodes measure very small voltages caused by the synchronized activity in very large number of synapses in the brain outer layers. EEG, whenever a data is interpreted, it should be described in the following formats like frequency, amplitude, sleep stages, duration, region of importance, and effect of maneuvers. First, coming to beta waves, just 2 points on each wave. The frequency of beta waves varies between 14 to 30. It originates in the frontal or central region, but can occur diffusely. It presents during the wakefulness with eyes open and drowsiness, but diminishes during deeper sleep. This is how a beta wave looks like. Then coming to alpha wave, frequency a bit lower, that is 8 to 13. It is also known as posterior dominant rhythm or alpha rhythm, originates in the parieto-occipital region bilaterally. It is present during quiet alertness with eyes closed. Beta waves during eyes open. Alpha wave during eyes closed. And it is suppressed by eye opening. One thing I want to highlight that 10% of the person do not produce alpha rhythm with eye closure also. Then coming to theta wave, it is the most common EEG pattern during the sleep, as theta wave can be seen in N1, N2, REM. Frequency a bit lower, that is 4 to 8, originates in the central or vortex region. It is also known as LAMF, low amplitude mixed frequency wave. Then vortex sharp wave, it is not a pattern of wave, it's a small wave, an isolated wave. As you can see, this is a vortex wave, sharply contoured waves. Duration of vortex wave is usually less than 0.5 seconds. It is maximal over central region, and it occurs during transition from N1 to N2. That is the vortex wave. Sleep spindles, frequency 11 to 16. These are the sleep spindles, you can see. Duration is more than 0.5 seconds, maximum over the central areas. It is the defining characteristics of N2 stage of the sleep, originates in the reticular thalamus nucleus. It can be seen in N3, but patients who are taking benzodiazepines, it is much more prominent as compared to the normal population. K complex, these are the K complex, high amplitude biphasic deflection, a initial negative deflection followed by a positive deflection. Duration is more than 0.5 seconds. Vortex wave duration is less than 0.5 seconds, but K complex duration is more than 0.5 seconds. It's the characteristics features of N2 sleep stages and maximum over the frontal region. Slow wave frequency is 0.5 to 2 and more than 75 microvolts. It is used to define N3 sleep, and when it occupies more than 20% of the epoch. It is also transmitted to the eye derivation. Why? Because as slow wave activity is more in the frontal region, and we are attaching our EEG lead here, so there is high chance that this EEG derivation will be transmitted to your N3 wave, slow waves. Sawtooth wave, this is the trends of triangular waves, often seen in the central derivative, 2 to 6 hours. It is the defining characteristic of stage R, but it is not required for your stage R. If it is present, it's okay. Otherwise, from theta wave also, you can diagnose your stage R. Then coming to EOG, that is electrooculogram. Recording of the eye movement is possible because a potential difference exists across the eyeball. With the front of the eye is positive, with back of the eye, the retina is negative. And two electrodes are placed, as you can see, right and left, at the outer conchae of the eye. And reference electrode is contralateral here. It is basically used for your sleep staging. This is the different patterns of your eye movement. That is slow eye movement, rapid eye movement, reading eye movement, and eye blinks. These slow eye movements are typically present when eyes are closed in drowsy condition and also stage N1 of the sleep. And rapid eye movement during the wakefulness or stage R. But the slow eye movement typically disappears during the N2 stage of the sleep. But the patient who are taking SSRI, that is selective serotonin reuptake inhibitor, in that condition, the slow eye movement might persist, along with rapid eye activity, which is known as Prozac eyes. Then coming to electromyogram, it helps in detection of the marked hypotonia during the REM sleep. Activity of the muscles below the chin are recorded and 3 electrodes are placed. And whenever you are suspecting like bruxism, PLMS, or REM behavior disorder, you have to attach the electrodes in other places as per your requirement. So monitoring the respiration during sleep, that is airflow, respiratory effort, arterial oxygen saturation, and carbon dioxide by EtCO2 and transcutaneous CO2. For monitoring the flow, pneumotachography is the gold standard for diagnosis. But this device quantifies airflow by measuring the pressure difference across a linear resistance. It is worn in the mask covering the nose and mouth. Bulky, can impose the resistive load of the patient. It is uncomfortable. It is basically for your research purpose. Coming to thermistor, try to understand the difference between thermistor and nasal cannula. This thermistor detects the changes in temperature induced by the airflow. That is cooler inspired air that we are taking inside your body and warmer exhaled air. So thermal sensors are generally adequate to detect an absence of airflow, apnea, but it is not ideal for detecting a reduction of the airflow, that is hypopnea. And thermal sensor signal also decreases when the nostrils are large or thermal sensor is further from the nares. But the major advantage of thermistor being is that we can see it has two ports. One is attached to your nasal cavity, another for your mouth. So we can detect both nasal and oral airflow. Suppose your nasal blockage is there, you can detect your oral flow. And direct contact of the skin should be strictly avoided. Nasal cannula, it detects the only nasal flow. During unobstructed flow, the inspiratory shape of the nasal cannula signal is round, but in airflow limitation, it is flattened. And around 10% of the patient, if you will see in patient undergoing polysomnography, are mouth breathers. That is why in those kind of patients, nasal cannula will fail to detect the flow. Monitoring the respiratory effort, esophageal manometry is the best thing, but it is of a research purpose. Most sensitive and accurate method is esophageal manometry. Esophageal pressure fluctuations are reflection of the pleural pressure changes during respiration. It can detect the feeble respiratory effort which are not picked up by the other device. It primarily used for detection of the RERA. Those who are interested, they can go through this paper in which we have used this esophageal manometry by putting an infant feeding tube inside the esophagus and attaching this infant feeding tube to intra-arterial BP line. It can detect also esophageal pressure. Then coming to RIP belt. RIP belt, the inductance of the coils changes during respiration. And as the inductance varies proportional to the cross-sectional area, it is converted to a voltage output. Accordingly, we can know the results. It is not 100% sensitive, but if it is properly applied, it is 90% sensitive. Best method for detecting paradoxical breathing. Paradoxical breathing means when your chest and abdomen moves in opposite direction. In case of obstructive sleep apnea, it is best thing to detect paradoxical breathing. Pulse oximetry, just one thing I'm going to highlight on pulse oximetry is that this ICU pulse oximetry should not be used in your polysomnography. One thing is there known as the sampling time. After what time your saturation is changing, it is picking up. The pulse oximetry used in your ICU setting, it has a sampling time of 3 to 5 minutes, maybe 5 minutes. So this kind of pulse oximetry you cannot use in your polysomnography. It will miss the desaturation occurring after an event. So the pulse oximetry that we are using in your polysomnography, it has a sampling time or average time of 3 seconds with a heart rate of 80 minutes. That is also recommendation of ASSM guideline. Then coming to ETCO2 measurement, it can be detected by your ETCO2 or transcutaneous CO2. So ETCO2 has certain limitation. It is inaccurate when supplemental oxygen or positive airway pressure is applied because ETCO2 you have to attach with your nasal cannula. So you cannot use ETCO2 during titration because titration you are attaching a mask to the patient. In that point of time, you have to use your transcutaneous CO2. The other problems being in that oral breathing or occlusion of the nasal cannula secretion, you cannot detect your ETCO2. If the tidal volume is small, a true alveolar sample may not reach the sensor. That is, in the disease lung, you cannot use your ETCO2. Transcutaneous CO2, it based upon the principle that heating of the capillaries increases the capillary blood flow, that increases the permeability to CO2, and that CO2 being measured by your electrodes. One disadvantage of transcutaneous CO2, I must tell that this probe should be changed every 3 to 4 hours to avoid skin irritation or damage, and mainly used for the NIV titration. As I've already mentioned, you should use transcutaneous CO2 during your titration study, ETCO2 during your diagnostic study. And tips for conducting a good sleep study, these are the tips we will discuss in the workshop station. Thank you all for your patient hearing.